So the first talk, will go straight away go into the first talk. It is tear function test by Dr. Gargi Sathish from Government Medical College, Kottayam.
Okay. Good afternoon, everyone. Going straight to thank you so much, Team Malapura and KSOS for this opportunity. So the tear function test, what are the essential skills and toolkits easily available? Now, from being a very simple disease, dry eye has evolved into a multifactorial disease with multiple dimensions. But do remember the two basic classification into aqueous deficient and evaporative dry eye. So one of the easiest tools available could be the questionnaires. Lots of questionnaires are there. The OSDI or the Ocular Surface Disease Index is a favorite one. We can translate it into the local language. And the advantage is that the patient can fill it even before we see the patient. So it can be a very useful starting point. So we get a score and we can start from there. Now, a tailor-made history probing into these details, which could be actually the cause of the dry eye in that patient, will be very, very helpful. Similarly, the clinical assessment should be focused on areas causing or related to dry eye, like the meibomian gland and secretions, the lid margin, the tear meniscus, etc., which will again help us in our diagnosis. Now, coming to the age-old test of Schirmer, which every one of us knows. Lots of controversies regarding its reliability are there, but definitely it is a useful test to assess the quantity of tear secretion. So especially, after washing hands, the Schirmer strips, the filter paper is now easily available in the 35 millimeter length, has to be labeled right and left, and the 5 millimeter is bent. There should be a good patient communication because it is quite an uncomfortable test and it does last for around 5 minutes. So without touching the cornea or due touching the conjunctiva, it has to be inserted between the lateral 1/3 and medial 2/3. Patient has to be very comfortably seated with the head resting. The patient can open or close. The recent consensus is the patient can gently close his eyes for 5 minutes. Without the air condition or the fan, that you all should remember, and the amount of wetting noted. It can be done with or without anesthesia, Schirmer 1 and Schirmer 2 with nasal stimulation. Whatever it is, if the Schirmer is positive, or rather if there is dry less than 10 millimeters, that is very significant, and less than 5 definitely indicates dry eye. Suppose, and it has to be marked and you can stick it on the patient file for future reference also. High false negativity is the main problem with Schirmer because of tearing when you are inserting the strip. Similarly, the next easy tool is the T-butt. We think it's difficult but very easy to perform. So you have to use a preservative-free solution like saline to wet the strip. Instill it, ask the patient to blink, shake off excessive fluorescence, put the cobalt blue. After a blink, you just time it and look out for the dry spot. Should not be a fixed dry spot, you all know that. So I don't know whether it's clear, but the first dry spot appeared around here at around 10 seconds. So less than 10 seconds indicates tear film instability. So it is actually quite easy to do, and the pattern of the breakup also gives an idea to what sort of a dry eye it is. Similarly, we have already put fluorescent, so after 1 to 2 minutes, just take some time to note the fluorescent staining pattern, which could also give you an idea of what type, is it evaporative or aqueous deficient. So many sophisticated instruments are there now, osmometer, etc. But these valuable easy tools like a questionnaire, Schirmer, T-butt and fluorescent staining definitely leads us on to our diagnosis, and we should treat the cause and not just the symptom of any dry eye. Thank you so much.